A very warm welcome to our very first Lung Foundation Lung Cancer webinar. The Lung Cancer Connect project is a Cancer Australia supporting people with cancer grant initiative funded by the Australian Government. The Lung Foundation acknowledges the traditional custodians, past and present, of the land which we live and work. My name is Claire Mulvihill, and we have a variety of people joining us this evening around Australia, patients, family members and carers and clinicians, so a very warm welcome to you. Now I'm just going to open up with doing some housekeeping before we go any further. So if you experience any technical problems, please let us know via the chat box or follow the prompts on your screen. If you can find your mute on your speaker of the computer, if you could please mute that. We don't actually get any of the background noise coming through. I encourage you to use your chat box to connect with other viewers and ask the presenters any questions that you may have throughout the next hour. If your question is not answered, we will still be in contact with you over the next few days to address your query. If there is any information that you may have missed this evening session, you will be able to access the recorded webinar at a later date uploaded on the Lung Foundation Australia's webinar. So the other important point I'd also like to make is that if any stage you feel vulnerable or you need to talk to somebody urgently, please contact Lifeline on 13 11 14. And they're available 24 hours, 7 days a week. Tonight's webinar topic is called Discussing the Needs of Newly Diagnosed Lung Cancer Patients, and it is with great pleasure that we are joined by 3 expert clinicians from the Prince Charles Hospital here in Brisbane. First, I introduce Dr. Con Fong, respiratory physician. We have Melanie Holland, our lung lesion diagnostic nurse, and we have Hannah Porter, social worker specialising in lung cancer. So to help set the scene this evening and open up discussion with our 3 clinicians, I'm going to provide a very brief scenario on a patient just to shape the discussion for tonight. So as you will see up there on the slide, we have a 65-year-old gentleman. His name is George. He lives in regional Queensland. He's a pensioner. He's a retired mechanic, an ex-smoker. He lives alone, but he sees himself as a fit, healthy, independent man. So he develops a cough over the past 3 weeks and he decides to go and see his GP. The GP does an assessment, listens to his chest and notices some fine crackles in that right lower base of his lungs. The gentleman, George, reports coughing up some green phlegm in the last few weeks, and so the GP starts him on a course of antibiotics. The gentleman returns 4 weeks later with increasing symptoms, shortness of breath when he exerts himself. He's constantly tired and he's now showing no interest in his food. The coughing, unfortunately, is persisting and increases when he lays down, and the phlegm that he's coughing up remains discoloured. So his GP orders a CT scan, which indicates a large right mass in his right lower lobe with a small pleural effusion. The GP then refers George to Prince Charles Hospital to the respiratory clinic for an urgent review. So here is the gentleman, 72 hours ago he was with his GP. He now ends up in your office. What are the types of things this gentleman, George, would you work through with him in this initial consult, and what would you start looking for with him in the history and the CT scan results that you have?
Thanks, Claire. This is a very important part of the journey for patients, and clearly it's a very stressful time. So by the time they get to us, we've always tried to work with the patients, their doctor, and their families to make sure this is at least as little stress in the journey as possible. So the main things for us to do is to try and confirm and ascertain that it is cancer, to identify what sort of lung cancer, and to think about the potential treatments. To do that, we need to find out a bit about the patient, how well and fit they are, what the risk factors are for lung cancer, and also their preferences, because We do this and make decisions in conjunction with the patient.
Right.
So in your history, you've told us that he's a mechanic, so we need to ask him about asbestos, because in the past, mechanics used to work with brake linings which contain asbestos. So we're looking for things like asbestos exposure, smoking history, family history of lung cancer, exposure to dust, diesel fumes, heavy metals, things that we know are linked to lung cancer. At the same time, we also ask about the medical history to ascertain their fitness for the test that we'll need to be doing, and also for potential treatments in the future. Yep.
So what you've emphasised there, Quan, is the importance of history and the links that past history exposure to occupational, environmental factors can have on the patient. But so moving on with that history in then looking at the diagnostics too, then you know that you have a lesion sitting there in right lower lobe of George. So how would you then approach that with George? You've got the history now. What is that next step to understand what is actually sitting there and what he owns?
Yes, thanks Claire. So hopefully by this time the tests are there, the CT scans there, and most of the time the GPs have explained to George, or his GP will explain to him what it means. And for us, at the consultation, what we do is examine the patient to look for abnormalities that would allow us to undertake a biopsy. We need to take a specimen of the cancer, which is always the easiest specimen to take, the safest, that will give us a diagnosis. The diagnosis will be of lung cancer and the type of lung cancer, and also look for certain characteristics that may guide treatment. Some of the modern tests include testing for certain mutations that will guide us in terms of deciding which treatment is suitable. So after the examination, we'll have a look at the CT scan, which we go through the patient and the family and carers to identify where the abnormalities are. And the diagnostic tests usually for lung cancer are two in the main. One is a bronchoscopy, a telescope look into the lung, a flexible telescope, very similar to looking in the stomach or your bowel for abnormalities, and then taking samples through that telescope. The other way is to put a needle into the lump, which is in the lung usually, through the chest wall. And that entails a little bit of anaesthetic in the skin, and then under the CT guidance in the CT scanner, a needle is passed into to take some samples of cells for testing.
And there are also, there's another diagnostic procedure, an EBUS, that some patients do call and want to understand a little bit more about the difference between a bronchoscopy and an EBUS. What would you be able to explain to the patients about that too?
That's a very good question, and we often in medicine we use a lot of jargon, don't we? Mm-hmm. So EBUS stands for endobronchial ultrasound, and what that means is in the bronchoscope, using the telescope, we're able to put a little ultrasound probe, which is very small, into the bronchoscope, and use that to guide us to take biopsies from either lymph glands in the middle of the chest, or allow us to biopsy small lung lesions, lung tumors in the edge of the lung. So those these different tools to help us get to the cancer itself to make sure that we take the right samples.
So with this gentleman, with George, it's very clear that the importance is understanding the type of lung cancer, the pathology of that lung cancer, and then understanding how to actually establish that through the different diagnostic approaches. So if someone was fit and well, and the lesion was quite large, would it be more suitable to opt for another, a particular procedure over another one?
Yes, that's a good question. So the choice of procedure will depend on what type of abnormality there is, and the likely yield from the test, the safety of the test, and also whether we at the same time are able to stage the cancer. Staging means ascertaining how advanced the cancer is. For instance, in George, it looks like he has a pleural effusion, which is a bit of fluid in the lining of the lung. And that would probably be the easiest way for us to take a sample by putting a little needle into that fluid, to drain that fluid off, to send to the pathologist for testing. So that would be minimally invasive, and that would give us the diagnosis as well as the extent of the cancer as to whether it involved the fluid around the lungs. So that's what we do. We look for the simplest, most effective and safest way of diagnosing the cancer. And if we can undertake some staging, finding out how advanced the cancer is at the same time, we do that.
And Melanie, so as the lung pre-diagnostic lesion nurse at Prince Charles, can you explain the importance of your role in navigating this patient through? He's seeing Quan, and he understands that he's got some diagnostic procedures to go through. What is the importance of your role in navigating this patient forward in the treatment?
So my role starts before the patient gets to an appointment with Dr. Fong or any of our clinicians. Basically, I accept the referrals to our hospital, from our hospital. I get them to the doctors to categorise the referral to find out how soon we need to see these patients. And then from there, I call the patients to offer them an appointment, and we have a discussion about why they need to come and have an appointment with our specialist. And most of the time, the patients are aware of why they need and why they're coming to see us. And they have a lot of questions about what will be discussed in the appointment, what they need to bring with them to the appointment, and those kinds of things. So we get to the point where I call the patient, we offer them an appointment, and we get them to come in. And so my role is to help support the patient, be the link between the patient, the hospital, and the clinic, and the doctor, and to help provide education and answer any questions that they may have about the appointment or potential procedures these patients may be having, and to also talk about any stresses or concerns that they may have.
So in your role, I suppose the most important part is demystifying that whole step in wondering, do I have lung cancer, don't I have lung cancer? And some of the questions that these patients come with, what are those fears that they have? Is it the unknown, or?
I guess, you know, it also starts with the GP and what information the GP has told the patient. And so some patients have been told that they potentially have cancer, so a lot of their questions are centred around that. And I basically just need to bring them back to the medical imaging and the assessments that we need to do, and just remind them that it's very difficult to tell by imaging alone what the potential issue is. And so I remind them that they're very good questions, that they should write them down, and then come to the appointment, and we can look at the medical imaging, have a discussion with the doctor, and talk about what the potentials are, if it could be a cancer or if it could be another pathology.
So talking about that diagnostic process, that both of you are very united in supporting the patient and guiding them through, what are the important aspects from the diagnostic procedures to actual staging? What type of scans would the patient, I mean, he's already had a CT scan. Is there any other scans that the patient may need to undertake to actually finalise that staging process?
Absolutely. So as you have mentioned, the patients have generally had a chest X-ray or a CT scan before coming to see us. And then another scan that is very helpful to the doctors in working these patients up for their assessments is called a PET scan, which is a full body scan, which helps show any changes in the body. Particularly, obviously, we know that there have been some changes in the lungs, and this PET scan helps us to look at other areas of the body, to see if there are any other areas of change, and to see if we need to do any other additional tests to see what those changes could be as well.
So this is a new scan that has really evolved over recent years, hasn't it? It's become more about gold standard in confirming the diagnosis.
Yes, it's commonly used now. It's probably the most accurate test, and in the past, and occasionally we still use older tests like a bone scan, which looks for abnormalities in the bone. And we often do a brain scan to look for any possibility of cancer in the brain. And then we look at other scans depending on the symptoms and the signs that we find in each every patient.
So it's been very thorough to the importance of establishing a really thorough, accurate type of lung cancer and the stage of lung cancer.
That's right, because those facts are very important for us to decide on what treatment options are best for a patient. Lung cancer is a complex disease, and you've already mentioned the pathologist and us, and we work together in a multidisciplinary fashion to work out what is best for the patient, depending on the type of cancer, the stage of cancer, and of course the patient's preferences and the fitness for treatment.
So I think that segues beautifully into opening up that discussion about the importance of a lung multidisciplinary team and the lung multidisciplinary team meeting. And I think it's now lung MDTs, as we call them in short language, as we're very good in the health profession to use acronyms. But to understand over the recent years, it's now becoming a gold standard in our practice, presenting lung cancer patients at an MDT. Could you just, between the two of you, share the importance of what an MDT, lung MDT is about, and what is the endpoint of an MDT for a patient?
Sure, maybe I'll start and say what, from the medical point of view, what an MDT does for us, and then Mel maybe can explain what benefits she gets from it to help the patient. So, from my point of view, we've just had our MDT today, in fact, with Hannah and Mel and all the other specialists. So the MDT consists of other specialists who are involved in the treatment and management of patients with lung cancer. And there's a typically lung specialist, a respiratory physician like myself, nursing team, allied health, psychosocial care, and then the other medical specialties, which will include lung surgeons, radiation oncology, provide radiotherapy, medical oncologists, provide chemotherapy and targeted therapies, palliative care physicians, pathologists who look at the actual biopsy specimens and give us an idea of what the tumour is and what it's how it may behave, and radiologists, which are radiologists who look at the pictures, the CT scans and the PET scans, as well as sometimes the radiologists who undertake the procedures like biopsies, needle biopsies. So we have the opportunity to present all the medical and scientific data so that we can work together and check all the different aspects of the diagnosis and the staging very carefully. We look at things like lung function and fitness and other illnesses that the patient may have to try and formulate a plan that is individualized for each patient. Every patient is different, every patient is special. We're always very careful making sure we work towards their wishes and their preferences, and we try and elicit their feelings and whether there are any underlying issues that we can assist with in addition to the medical issues. Mel?
What I get out of the MDT is obviously knowing that the patient has been discussed amongst all specialists, and it's a good opportunity for me to know where the treatment plan is going for the patient, and so I'm very aware of what their plan is, and once we have delivered the news and broken the news of a cancer diagnosis, the patient would then have many questions about where their treatment is heading and those kinds of things. So the meeting is an opportunity for me to get a very good understanding of the patient's care, and it's also an opportunity for me to be able to liaise with other members of the MDT. So another nurse that I work with very closely is a cancer care coordinator, and working with her to manage the referrals for new treatment and things like that, so that we can safely hand the patient over in a timely manner and get good treatment started for the patient.
So it's a meeting where you come together with all the experts, as you clearly explained. You're collaborating, and it's interesting, you probably would go in with sometimes preconceived ideas, but after having a robust conversation with all the experts and then having a balanced approach, sometimes that preconceived idea may change in treatment and you may get a better outcome because of the opportunity of coming together and talking it through with one another.
That's absolutely right. And even today, every day, sometimes we have an idea of how something should go, and then we see something that's different. and we have differences in opinion, and that's where we are able to use those different opinions in our discussions with the patient, because sometimes we're not sure how to treat a certain thing because there's a rare thing or where there's uncertainty in some of the tests. Not every test gives us an answer. Sometimes the tests are equivocally, maybe this way or that way. So those extra opinions are very helpful in giving the patient additional opinions. I've also forgotten to mention that one of the key members is the palliative care physician. So psychosocial care and support through this very difficult time for the patient and their family is very important. And as many of the cancers we see, unfortunately, do progress to a later advanced stage, palliative care input is very important, and early referral is often very beneficial.
Absolutely. And before getting into the psychosocial aspect a little bit further, the step after the MDT, so you've presented the patient, you've all come together, you've collaborated on the best treatment plan for this patient to achieve the best outcome. Where does the patient then receive that information? Do they come back in from the home and then they meet with you, Mel and Quan, or how does that normally work?
So it's all about timing. Initially, at the point of the first appointment, when we're talking about diagnostic tests, we say that we're going to do a biopsy of a certain type, so whether that be the needle test or the bronchoscopy, and then we always start discussing when results will be available and how we will go about talking about those results. We present all new cancers at our MDT, and we always seek permission from the patient to be able to present their case at the MDT meeting.
Yes, we do. In general, we like to see the patients. Yes. Obviously, George is from far away, so
he's regional.
Yes, right. So in many jurisdictions, the use of telehealth has been very helpful.
Yes.
But breaking new news can be very stressful. So in general, our principle is to talk to the patients, allow them to have their family and friends and carers there with them, to allow them time to ask questions. We provide written information as well as verbal information, because it's very easy to lose sight of all the amount of information we tend to give, which is a lot. And we encourage them to write things down and come back to us. Mel gives them her phone number so that they can contact her for further support. And of course, we have Hannah and her team's work as well in providing the extra psychosocial care that's key.
So the supports, the education resources that you provide, Melanie, what are those resources and what do they look like for the patient?
So the resources that we provide to our patients come from the Australian Cancer Council, and we also have provided information from the Australian Lung Foundation as well. So we know that it's trusted information, it's accurate information, it's being researched very thoroughly, and we know that it's conventional treatment. So we provide that information to the patients. It's quite a lot of information, and some people are visual people and like looking at pictures, and some people like reading, doing lots of reading. So it's all, and we remind the patient that it's entirely up to them what they would like to do with the information. We're not going to force them into reading it, so we just provide it in the hope that it would be helpful to them. Because obviously coming in and having your results read and this, discussing what we have discussed in the MDT meeting can be very overwhelming. So by providing this information to the patients, it's a point of reference for them to go back and check things, and we do make, we highlight things in the books for patients so that it makes it easier for them to go back at a later time to revisit that information.
And I think that's a really important point when, you're sitting there in an office and you're receiving the bad news of your diagnosis and understanding the extent of it. You only obtain such a small percentage of that information, and so to receive that written material, and as you say, Melanie, you're highlighting the main points of that diagnosis so that they can go back over that information, written information with visual pictures, etc. But I like how you really are that conduit between the hospital, the regional hospital possibly, in George's situation, and also the home. You know, they've got that connection. But I suppose Hannah always saves the best to last. You know, there's a lot that's been unpacked here with George, and you know, he's now been presented at the multidisciplinary team meeting. His pathology's come back that he's a squamous cell lung carcinoma, and he's stage 3B, so he's more on that advanced staging of his disease. And it was decided at the team meeting that he's going to receive his treatment back up in the regional hospital. Could you just walk through the many patients like George, but all coming with their own unique makeup, of how he must be tracking at this time, and what are the types of emotional and practical support that social work can bring together so well and such a vital part of a multidisciplinary team?
Yeah, we see many patients like George who 1 minute are happily living their lives, they're independent, they're fit and well, and the next minute they're tackling a really significant health issue that's completely changed their lives. So people are usually suddenly telling us they're completely overwhelmed, they don't know how to take this, and they can't believe this is happening to them. And so it's quite normal for people to feel some very intense reactions, distress, sometimes guilt, fear, worry, anxiety, and troubling physical symptoms like sleep and all these things that accompany all this. So it's not surprising really when we think about cancer, it's quite a threatening thing to us, and it threatens how we live our lives, our income, our family, and all these sorts of things. So it's quite normal for people to feel acutely stressed, and I'm often walking that journey through and helping people navigate those things and the challenges that them and their family are coming up with. And so when people get this news, they're often really, really shocked. They're not prepared for this. They're trying to take this in, but we know when people are really distressed, or hit our first word, cancer, and we're so wrapped around trying to get their head around that word and trying to understand what happens next. And so it can be really helpful for people to be able to have someone to talk and debrief those things through and come back to and try and work out what decision making they need to now do and what their choices are in context with all their other personal lives and family. And so that can be really helpful in contacting from them. You know, further questions come up with the nurse and the other team members and the doctors as well. And so people often have a lot of concerns around that point in time, but they don't want to burden their family with some of these things. They're worried about or disclose these things to friends and close people. So it can be very relieving for people to talk those issues through with a health professional, where they don't have to worry about burdening us or upsetting us. So as social workers, we're often, you know, openly listening to people's experiences and helping them strategize and find resources to cope with all of these things. And so some things people need to look at is then telling their nearest and dearest the diagnosis and how they explain that to them and how they manage their responses, especially if there's children involved. And we know that it's equally distressing for partners, maybe even more so, so we're often supporting them as well around this whole process. People are often needing to broach that topic then with their work and their employers, and what are their employment rights and how do they navigate that. And just the very experience can be really stressful and really draining. So learning some stress management and some relaxation exercises can really help when people manage this really stressful period of time while they're adjusting as well. Yeah, so that's some of the emotional things around that stuff. Yeah.
So it's very complex, isn't it? And as I said right at the beginning,
he's now got to think about suddenly reorganising all of his priorities and his finances, because he's got to suddenly go and do treatment. So suddenly this is the top of the priority and everything else has to fall underneath and be recollected as well. So sometimes we can help people assess how this is going to affect them and then manage this in the best way possible, because people are often experiencing a loss of income while they're doing this. They either have to take time out of work, or their carers or their families have got to take time off, and there's all the extra expenses that's coming to hospitals and travelling and parking and so forth. So we really want to make sure there's no financial or social barriers of people getting the very best care for them. Absolutely.
So with George been going back to the regional hospital, and he's obviously would have developed a connection with you, because you've heard him, you've listened, you've reflected, acknowledged him, and which are such powerful, simple but such powerful tools to embed into somebody. He's developed that relationship there, but now he's going back to his regional hospital. What's the support social work connection? And I think for you, Melanie, with the nurse support as well. Con, you've done the diagnostic stage, so you've done the setup. But how does that care continue on then for someone like George in this situation?
We can often work out what people need from this point, and we've got colleagues that work in those regional areas and so forth. So we can go through with them about the stresses they're having with managing that cancer, and connect them into local services, Cancer Council, for example, and some of those supports, looking at financial matters, reviewing income protection policies, and Centrelink, helping people navigate that. And with George, he might need help looking at Centrelink, getting an age pension healthcare card if he hasn't done that, applying for those sorts of things. And so where we identify those needs and things as well, like just coping, that lung cancer can be an incredible burden, and just doing normal everyday things like cooking for yourself, and you need to conserve that energy, and then you don't want to eat, and then you have further weight loss. And so there's lots of government subsidised services that can help manage those things. So we can educate people around those things, and they know how to contact them, and also help link them in and refer locally for those support services to start, or other allied health professionals closer to their regional area, or cancer care nurses to help coordinate all that stuff when they get back there. So usually that's an incredible relief for people, because they feel sometimes very scared by the idea that they're not going to manage as they were before and independent, and they're going to become a burden to their family. That's not the case. There's so much wonderful support out there. It's about connecting to people and making them feel isolated.
And I think that's the key, isn't it? Is first of all accepting that you need to have help, and that can sometimes be very hard. Someone like George, who's very independent.
It really challenges your self-concept about who you are in society and your role and so forth. And sometimes that's a big shift in thinking and learning, these things can actually help me be more independent and function.
And it's asking the question, I think, as well as a patient, empowering yourself to ask the questions, ask your clinicians, what supports can I access? Because if people don't know, we won't be able to bridge those concerns for you. And sorry.
And they're very worthy of those support and so forth. It really, really makes us happy to try and connect people, to see people coping better and so forth.
Interesting. We've had a couple of calls of recent through the telephone support line here at the Lung Foundation about the travel scheme. So if you live, patients who live regionally and you need to come down, and I know in collaboration with Cancer Council, who are fantastic in the support there with travel schemes. Could you talk a little bit more about what travel schemes mean and how patients can access them to help them get to appointments, etc.?
Because in Queensland, we're spread out so far from different centres, and there's similar schemes in each of the different states, but it's made by the health system to alleviate that financial burden of having to travel and accommodation and so forth. So for people that need to travel more than 50 kilometres and are eligible for the scheme, they can apply for that, and that can help with the cost of travel, accommodation as an outpatient if they need it, if they're eligible, and if they need a support person to come with them for that trip as well. So it's a really good resource to access, and if you're having trouble accessing that scheme, you can talk to your cancer care coordinator or your social worker to help you get on board with that.
Fantastic. And sometimes, like in George's situation, and I think really for any patient, doesn't matter where they've been diagnosed with the lung cancer, early stage or more advanced, advanced care directives are such an important thing that sometimes I don't think we, as even clinicians, I don't think we think about the advanced care directives. And is that something that you would, or Melanie or Con, is that something that you would approach with your patients? And obviously it's with timing and when to raise that.
And it can be an empowering thing to think about these things sometimes because knowing that you've had that discussion about what to do if you need it with somebody and they need to make that decision in an enduring power of attorney, or you've left some instructions about what medical treatment you would like if you're just not able to speak for yourself at some point in time, can be quite reassuring. So it's really good to have those discussions and get around to looking at those documents. They can be incredibly valuable.
And how would they access those documents? Is that something that you would be able to bridge for them, Hannah?
Those
or
documents,
a social worker?
Yeah, those documents are free online, or you can see your social worker for a bit more guidance and support as to how to fill those in.
So there's something also in just moving a little bit away from the emotional and the practical supports, but we were talking a lot right at the beginning about the diagnostic process, and I'm aware that the optimal care pathway, the national pathways are now released and used as a guide for improving practice and achieving the best outcomes for patients. Is it something that you could maybe expand, maybe Con and Melanie, to talk a little bit more about what these optimal pathways are and why they're so important for patients?
Sure, sounds good. Maybe I'll give a bit of background to the types of information that doctors use to help guide us, which will be the care pathways and guidelines, and then Mel can say what impact it makes on our daily work, maybe. So I think as medical professionals we have guidance, just not only from the research that's done, and we can talk about clinical trials in a little while, how important those are. Those trials and that research ends up being made into guidelines and efforts like the optimal care pathway. So lung cancer guidelines are available in Australia. They're hosted by Cancer Council Australia, and it's on the website. It's a wiki guideline, so people can go and visit that and have a look at the different guidelines. They're grounded in many years of deep research and very specific methodological ways of looking at data and coming to some conclusions. The optimal care pathways are parallel, are complementary to them. They've been developed by Cancer Council Victoria at the instruction of the National Cancers Expert Review Group, which is part of government. And now these optimal care pathways, which are a consensus document and guidelines from specialists and people who are expert in the field, are now available to us. They've been endorsed by the Australian Health Ministers Council, therefore they'll slowly filter down to daily practice through the different state governments and jurisdictions, and they've been designed to help us all, healthcare professionals, in our daily work to help ensure that what we do represents the best effort we can make for our patients.
Right.
And so Mel, how does it impact on our daily work?
So I guess we're looking to get the best outcomes for patients, and these pathways help us achieve good outcomes for patients and ensuring that we're in keeping with what the rest of the country is doing. So it's a good point of reference for us to ensure that we are meeting these guidelines for the benefit of the patient and their families and their treatments and things that progress from there.
And importantly, they also are versions for patients, which are the same information but de-jargonized so that we're on the same page and patients can see what the goal is for each of the things we do. There are also guides for general practice because, as we know, the first point of call for the patient is through the GP. And of course, coordinating that part is difficult, and getting that right is very important as well.
There is a question that's come from the patients and who are watching tonight, that can patients come and join in on a lung NDT?
That's a very good question, and one that's often asked. Firstly, I guess we can say their MDTs for cancers generally are increasing in availability, and certainly for lung cancer they're increasing, and in fact the Lung Foundation of Australia has to be congratulated because you host a registry, a database of all the active lung cancer MDTs. So that's very useful for patients and their families to seek where to have help from an MDT. Now, different MDTs have different ways of working. Some MDTs will discuss patients and then feed that back to the patients at a later date, or that afternoon, or later that day. Some MDTs will actually involve patients, and the patients will be speaking to different doctors. So it depends on the circumstance. I guess most MDTs are now very busy because we try to get every single patient into the MDT so they can all benefit. Everyone can benefit from the collective expertise. So most of the time, I think the patients will be discussed, and then the information is fed back because of the sheer volume of work.
Yeah. And I think it's the patient confidentiality as well, but with the sheer volume that it's preferred that all newly diagnosed lung cancer patients are presented at an MDT, and it's the coordination of that in the time. But I suppose the most important thing is that the information and the final decision from that robust conversation that makes up an MDT is then translated back to the patient accurately.
Absolutely. So that's part of the process, these optimal care pathways and the guidelines, is to explain that the discussions are documented clearly and carefully and communicated not only to the other people providing care, but to the patient and their families and the general practitioners and then the other people involved with their care.
So it's that flow-on of communication between secondary healthcare, which is you in the hospital, to the primary healthcare, to the GP. And I think that's the challenge there is streamlining that information back to the GP, especially in George's situation, knowing that GP is going to be a real gatekeeper and it's going to be so pivotal in his care, and how to continue on with that support from a practical and emotional and from physical sense of it all. So with for George, he's going back to regional Queensland, and it's the supports as well that are going to be very important. How do we encourage healthcare professionals to refer patients to support groups? Cancer Council do fantastic supports nationally. Here at the Lung Foundation, we provide telephone support groups and about to start a face-to-face support group. But how do we get that message out to healthcare professionals to utilise the supports for lung cancer patients? Because as we know, lung cancer has the highest psychological unmet needs over all cancers, and it's something that really here at the Lung Foundation we're trying to improve, but it really starts at the coalface at the hospital. How do you chat?
We're also having that conversation both one-on-one with people, because we're wanting to find out what supports they have and connect them up with people. And sometimes family and friends are wonderful. Sometimes they're not able to listen or just understand people on the level that they are experiencing things on. So if that's the case, connecting people and just telling them that these things are happening and they can join in on them can be really helpful on a one-on-one basis, and then they can be invited to join those as well. So I guess it's about all the team being aware that these things are available, and having information in waiting rooms and stuff where patients are going in to get their treatment and so forth, for patients to access it as well.
And getting the message out to regional rural Australia, and I think that's the job of Lung Foundation and the job of Cancer Council to keep pushing that.
And people can feel connected no matter where they are then, particularly if you're feeling quite isolated in these regional places where there's not a lot of other people with the same experiences that you're going through. You can then connect up and access that support.
Because I think that's where the support groups do break down that isolation.
Yeah.
It allows patients to come together, to be heard, to be acknowledged, to feel that they're not alone anymore.
They're not the only one.
It can be very valid.
You know, very often we hear patients, you know, come from good, supportive families, but they acknowledge it, but move on, or mum or dad or grandma, grandpa, they look well.
Yeah.
You know, and I think that's the challenge that we're facing now in lung cancer, is that there is that changing face of treatment, so to speak, as well. So we have patients who look incredible, but within themselves, they're actually fighting a daily battle of living positively as well as they can. So I think that's the importance of that psychosocial element.
Absolutely.
So important.
And the other challenge is to reach out to make available these supports and the resources to people who may be left, may have a gap in reaching services. People who are on their own, people in rural, remote, who, you know, the people in this call are lucky, I guess, in a way, in that they're able to access this sort of support. But there are many people out there who may not have resources or the ability to access this. And it's more of a Cancer Council Lung Foundation, all of us health professionals. And in fact, we're hoping in the future to work with Lung Foundation and other stakeholders to develop a national alliance of people, not just healthcare professionals, but also support groups, cancer councils, non-government organisations, to bring people together so we can make sure that what we know works effectively is applicable to all the people who deserve to have this care, to address the gaps.
Absolutely. And I think it comes to say, in summary, that lung cancer isn't a cookie cutter cancer. You don't have a cookie cutter approach to diagnosing and treating lung cancer. And so I think it's seeing the patient as an individual, approaching them uniquely, and it goes with taking in that past medical history and understanding them as a whole, understanding that support structure. And then from there, presenting them at the lung multidisciplinary team meeting, ensuring that you're going to get the best outcome in regards to treatment for the patient. And naturally, we're going to, the patient, like George and like many other patients on with us tonight, you know, it's a very fearful, daunting, overwhelming time. So to have a team that is collaborating and working together as a team is just so important for a successful outcome for that patient. And always having that connector back to the hospital. And I think it appeases me to be in this role, to know that when I have a patient call, that I know that there is someone as pivotal as you, Melanie, to then you know, empower that patient and network them into the right area of the hospital, which is so important. So, in summary, we have talked a lot about lung cancer and the early diagnostic stages of lung cancer and what it means and the impact it has on the patient. There are many resources, as we did discuss as well, that the Lung Foundation does offer patients. There is my role as a lung cancer support nurse, providing the telephone helpline, and that's available from Monday through to Thursday to listen and to guide you where needed. We do have an online forum which is actually currently being redeveloped, which is really exciting, and will be launched shortly. We have 3 telephone support groups currently running within Lung Foundation Australia, and we're about to embark on a young telephone support group in the middle of this year, which is very, very exciting for us to know that we are able to support, I suppose, the changing face of lung cancer patients as well. We also have the Australian Lung Cancer Trials Group, and we do have up-to-date information about clinical trials, and I think it's something we didn't really touch a huge amount about tonight on clinical trials, but I think we could actually dedicate a whole webinar to clinical trials and the importance of knowing about clinical trials and why as an integral part of your lung cancer diagnosis and treatment. And you're also probably aware that every November this year, every year we do have a Shine a Light on Lung Cancer Awareness Month, which you can become involved with throughout the year if you wanted to. So if you wanted any further information, I encourage you to contact Lung Foundation on our free call number 1800 654 301 or Cancer Council 13 11 20. We have fantastic supports and resources as well, and we both collaborate really well together. So I'd like to thank you very much for joining us tonight. I'd also like to sincerely thank Con, Melanie and Hannah for your expert knowledge and generosity for coming here and supporting our very first lung cancer webinar. I encourage you as participants to complete a survey that will be emailed to you at the conclusion of this webinar to provide any constructive feedback or suggestions that you may have so we can continue to deliver educated and well-educated lung cancer webinars in the future. So thank you for being part of our very first Lung Foundation Australia webinar. We look forward to delivering further educational webinars in the future and assist you in moving forward in living as well as you can with lung cancer. Thank you and good night.